Okay, well, I am Marie Harvey. I'm the Associate Dean for Research in the College of Health, and I'm stepping in today on behalf of our interim dean, Rick Sharfstein, who sends his regrets that he's not able to be here today. And I'm delighted, though, to see all of you and to welcome you. And before I introduce our distinguished speaker, I do want to take a moment to recognize the person who made today's lecture possible. So, Tammy, can you please come up and join me at the podium so we can recognize you? And so, so as many of you know, Tammy Bray, Dr. Tammy Bray, served as our dean of the college from 2002 to 2016. And she established the Tammy Bray Endowment in Health Leadership and Innovation with her husband, John, and with the contributions of alumni and friends. The endowment supports this lecture that brings high-profile health leaders to campus to inspire students and faculty in the community. So we are grateful for your vision, Tammy, and we are happy that you're here today. Thank you. So it is now my great pleasure to introduce Dr. Joshua Sharfstein, a distinguished leader, a visionary public health expert, and an advocate for advancing health equity. He's the perfect person to provide this evening's lecture as we confront the sobering realities and the lessons learned from the COVID-19 pandemic. His career spans decades of tireless dedication to improving public health outcomes and to safeguarding communities against emerging threats. He received his medical degree from the Harvard Medical School in 1996 and has garnered a wealth of experience from his roles in the academia and in government and in public service. He is currently Vice Dean for Public Health Practice and Community Engagement. He's Director of the Bloomberg American Health Initiative and Professor of Practice in Health Policy and Management at the Johns Hopkins Bloomberg School of Public Health. He has previously served as Secretary of the Maryland Department of Health and Mental Hygiene, the Principal Deputy Commissioner of the U.S. Food and Drug Administration, the Commissioner of Health for Baltimore City, and as a public health advisor for Congressman Harry A. Waxman. He's an elected member of the National Academy of Medicine and the National Academy of Public Administration. This evening, he will draw upon his experience and his expertise to offer invaluable insights, thoughtful reflections, and recommendations to fortify our preparedness in response to future global health crises. Through his nuanced analysis, he'll challenge us to confront the shortcomings exposed by the COVID-19 pandemic and to embrace innovation and collaboration. Please join me in extending a warm welcome to Dr. Joshua Sharfstein.
Well, it's a real pleasure to be here. Thank you so much to you, Dr. Harvey. I wish you had lowered expectations a little more in the introduction, and it's great to be here with Dean Bray. I had a great chance to talk with her last night, and I had such a great time with the students today. So thank you all for coming out. They said, what shocked you about the students? And I said, what shocked me about the students is that they were not on their devices. And that they were just so present and engaged and had such great questions that it was really inspiring. So I am going to see if I can figure out how to get this up here. Okay, so my talk is Public Health After the Pandemic, How Can We Do Better? And if you came here wanting me to call balls and strikes and all the things that went wrong during the pandemic, I'm not going to do that. This is more forward-looking. But I will talk a little bit initially, early on, about the big picture here. And I want to start with defining public health. This is my favorite definition. There are a few of them out there. But what society does collectively, sometimes it says what we as society do collectively, but society does collectively to assure the conditions for people to be healthy. And the key words here are society, collectively, and people. So it's really what we do together for ourselves that is public health. And when you think back on the pandemic, it was a brutal experience in the United States. We had more than 1 million Americans die, one of the highest per capita death rates in the world. This is after a report came out right as the pandemic was starting, or right before the pandemic, that ranked all the countries in the world and said, the United States had the best preparedness system, was better prepared than any other country for a pandemic. I don't know what organization released a report like that. It was Johns Hopkins. Anyway, I'll just, let's just say that's not how it turned out. We had one of the highest per capita death rates in the world, enormous disparities by race, ethnicity, class, morality, politics. It was a miserable experience. And it was a failure of public health in the sense that it was a failure of what we as a society do collectively to assure the conditions for health. We did not mobilize a society-wide response like other countries did. I'm married into a Norwegian family. My mother-in-law loves Norway. She's from Norway. She lives in Norway. In Norway, for a long period of time, they were subsidizing funeral homes because they had negative excess deaths during the pandemic. A very different experience than the United States. So that's just the beginning of the challenges for us, right? It wasn't just that so many people died. It's that a lot of people we're very frustrated with public health. We're very angry at public health. Some people call it the crisis of trust in public health. Public health officials had a miserable experience during the pandemic, many of them, not all of them, but in many places, they were attacked, sometimes like physically, many times with threats. And that has led to a bit of soul searching in our field. And I think that when you think about the pandemic and all the challenges that it brought and all the pain that it brought to the country and to people who have been spending their lives devoted to improving the health of their communities, it's a hard conversation to have. It's hard to think about. Sometimes it feels too soon, but I'm going to plunge in here. And I think under the what went wrong, there are a number of theories that are out there. Here are 6 of them, Some of them I call outside the house, so things that are happening outside public health, to public health, and some inside the house, things that we may have done that could have been better, and we need to think about. Outside the house, underfunding. Public health departments were unprepared for the pandemic, in part because we had antiquated systems and loss of a lot of staff. Misinformation and just the rise of just social media and the ability for people to organize, very nasty campaigns through social media was very, very difficult. Really not our fault that sort of surged just as the pandemic happened. Political interference, which happened in many places, and ideological polarization, so that like whether you got a COVID vaccine became a marker of your political persuasion, which really is just so bizarre. Can you imagine people saying, whether you get cancer chemotherapy, I'm not going to get cancer chemotherapy because this is my political party, but that's how people felt about COVID vaccination. It was a reflection, in my opinion, of the deep polarization that exists in our country, not the fault of public health, but having a huge impact on the field and the response. But then there's some things inside public health, and that's where I want to focus a little bit. Just want to mention the first one. I put it in quotes here because there is a critique of public health that might be called that public health was illiberal. It was too quick to make up its mind. It asserted things and stuck to them for too long. It didn't consider other values just besides reducing infectious disease transmission, like the harm to children of not being in school and other things like that. That critique has different forms, and I'm not going to talk about it too much tonight. I'll just say that I recently did a podcast with Sandro Galea, who as the dean at BU, who wrote a book basically saying this is what he thought was a big problem, and I disagreed with him. I think that we agreed a little bit on some of the things that happened, but fundamentally, I think my view is that public health officials and public health departments and the world of public health did its best to figure out what was going on, and it was some of the interference that happened and some of the fundamental obstacles made it very difficult. I agree, that there certainly were moments, and certainly social media is a miserable way to exchange ideas sometimes. But I personally am somewhat skeptical of that critique. But if you want to hear the full thing, you could listen to our podcast about that. I am not going to talk about that. What I want to talk about are two issues here: insufficient connection to communities as a core issue during the pandemic, and inadequate public engagement. Okay, so I'm talking about two things that are kind of under our control, under the control of academic public health, the public health departments, and how that can be a lesson for us for the future. And so the basic thesis that I'm going to advance is that putting the public in public health is a really important goal for 2024 and beyond. So just to talk about, well, why is there a gap? Why is there a gap? First, let's talk about between public health and communities. I had such an interesting meeting today with the Extension School group, which talked about some of the mistrust of public health that exists. Here are a few reasons, not every reason, but a few reasons. One, the inadequate resources for public health. Public health has really shrunk in many parts of the country, particularly starting with the recession of 2008. Where since then they've lost 40,000 workers. So you don't have a lot of people from communities who work in public health departments. Many public health departments are really bare bones. Fewer achievements because public health has sort of been trying to just survive. And that means less understanding for people what public health does. Fewer positions for community health outreach, fewer resources to share with community partners. All of that, I think, had the effect of maybe isolating public health a little bit. And, people go into, this is going to be a completely maybe an assertion without, I'm not going to have any studies to cite this, but I think perhaps some people go into surgery because they want to save people's lives with their hands, and they feel like, that is an amazing thing to do. And in general, I think they appreciate the credit they get for that. People go into public health, they're not necessarily looking for credit. When you save someone's life, they don't know that it was them whose lives was saved, And so people in public health, they're trying to survive, but they're not out there, beating their chests or talking about what they've done with their bare hands. They are trying to survive during this period. There's also other reasons for a gap between public health and community. There's a not great history in public health. And that creates problems. Obviously, you have the Tuskegee study, but there's a lot more to that history. There's a whole lecture that could be given about that history, where public health had a connection to the field of eugenics. Public health was involved in sterilization activities in some places. Public health comes from an era where a lot of good was done, but there were a lot of ideas that also inflicted a lot of harm. And so you have that barrier to overcome. And then another reason is that public health structurally often has gaps for hiring and working with people from the communities that it's trying to serve. So the professionalization of public health is an advantage in the sense you get people who understand epidemiology and biostatistics, but the over-professionalization means you can have a gap between public health and a community. And that manifests itself in inadequate career paths for people to join and get promoted, few job descriptions. Just recently, only in the last few years, have community health workers and public health really started to come together at scale. And And, so that contributes too. I think that's kind of a structural reason. And finally, I'll say that the research side of public health, oftentimes because of structure and people and a whole bunch of reasons, has not been as engaged with communities as it should be. And oftentimes people get a grant and then they run to do a project. And the community feels like that the study really hasn't fully engaged them. And, there's a whole movement of community-based participatory research that tries to undo that. But there are many, many years of non-community-based, non-participatory research that has happened in public health. And Lena Wen, one of my successors as the Baltimore City Health Commissioner, she tells the story after the unrest following the murder of George Floyd. She sent public health workers around Baltimore in areas where the pharmacies closed and there were other problems, all the chaos. And she said when health workers knocked on the door, they said, "Oh, who do you want me to vote for, or what study do you want me to participate in?" And was just a really sad reflection on the ability of public health to get out there and do things that are meaningful to people, and also kind of how people perceive research sometimes. So what can be done to close the gap? I'm just going to run through some things. We're talking about making public health more community focused and engaged and participatory. It's really important to have a diverse workforce. So I'll start there. It's a huge problem in medicine. It's a huge problem in public health in many places. And I'll just say that, just to point out, this is the, I think, Black Against COVID report, that where public health officials and physicians were able to talk to their own communities, that you saw a big response during the pandemic. Is very, very important. Second, funding a community health workforce. There were some federal grants. Unfortunately, the idea of a public health AmeriCorps got defunded after it was funded, which is, I think, really unfortunate. But a number of places did take the federal funds and invest in community health. Baltimore was one of them. Baltimore did not do contact tracing by hiring a big firm to do telephonic, calls to people. Instead, Baltimore hired 300 people from the city neighborhoods that were most affected, people who'd lost their jobs, to do contact tracing, resource connection, and ultimately door-to-door discussions of vaccines. And the results were very positive for the city. So I think that the idea that public health needs a community health workforce is an idea whose time has come. And then in order to do that, you really have to have a career path. It can't just be you get to be the community, health worker, the peer advisor, and that's it. You really need a career path for people, ways for them to get credentialed if they want, or ways for them to get promoted if they want to stay in that exact kind of work. But it's really limited implementation. And, it's I think, a challenge to the educational field to think about how to support people who are from communities, have a lot of lived experience, can really add to public health in their communities without over, credentializing it and making it actually harder for people to join public health efforts. I'll just say I was just really impressed by the discussion of the extension school and the work that happens, between people in the extension program, I should say, here and across the state. It's a really interesting model and one that can help public health departments bridge that gap. Just to mention a few things on this about academic institutions. And let me just pause. I am going kind of fast because I have a lot to say also. And I want to make sure there's time for questions. When I was in medical school, I was somewhat traumatized by all the people who showed up and talked to us for an hour and never left time for questions. And so I vowed I would never, ever, ever be me. So I promised to leave time for questions. At one point, we had this very distinguished dermatologist come, and he was like, he was going through rash, every slide. And if someone asked a question, he'd go, I have no questions at the end. He had a bow tie, is very tall, very proper. Questions at the end. And you get to the end, and he goes, I'm sorry, there's no time for questions. And someone in my class yelled out, what about one question? And he said, Okay, one question. He said, is it true that acne on the back is called backney? That was the most deserved question in all of medical school for me. After that guy said no questions. Okay, so what about the role of academic institutions? And so a few thoughts here. That academic institutions, I think, have a really important role in public health, both to model and teach and do the work of community engagement. This is a definition of community engagement, the process of working collaboratively with and through groups of people to address issues affecting the well-being of those people. And there is a whole taxonomy of community engagement. I won't go too deep into this, but there's outreach where you tell people about things, then you can consult with them, then you involve them, but ultimately you really want to collaborate with them and even share leadership. This is a project we're going to work on together, and here are our roles. And interestingly, we've tried at Johns Hopkins to adopt those principles, and we have guidance for people doing work in communities. And part of that guidance is the very first thing that you're supposed to do is sit down and really be honest about who's doing what and where the decisions will get made and how they'll get made. And we started doing work with a nonprofit in Baltimore that is very much about particularly economic success of Black men in Baltimore City. And the director called me and said, we just had a kind of strange meeting. And I said, what was that? I said, well, the team came and they sat down. They said, we want to make sure this is a fair partnership and we want to map all this out before we even get started. And we had this whole meeting and they showed us all these statements and then we all signed off on it. And they said, this never happened before. I said, well, how did it feel? He said, it felt pretty good. It felt pretty good. And that partnership has really blossomed. There's also critical service learning, which is a way of doing classes where people are actually doing work. And oftentimes the community organizations are the teachers. We have a number of service learning courses at our school. Instruction on structural racism and discrimination. I had a great experience with the class today. This is an example. We have an organization in our school that helps faculty develop service learning courses and works with about 120 organizations in the community on a bunch of different topics. There's a whole technical assistance effort to try to help people do good community-based participatory research. That's a whole other lecture, like how to do that. But that's just a really important idea. And increasingly, we're trying to work with our institutional review board to try to catch projects as they're going in to try to get them to be as strong as possible before they're implemented. We have at the School of Public Health what we call the Baltimore Community Engagement Committee, which has both members, community leaders, and leaders from the school. We talk about the school's work in Baltimore. We're trying to improve it. We do research collaboratively with them where we interview faculty who've done projects in the city, their community partners, how's it going, what can we learn, and we're constantly trying to figure out, what we can do better. And finally, I think this is something that is very obvious as part of the extension program here, but to try to join collective impact projects rather than try to do everything yourself. And the collective impact projects are where there's a goal, a shared goal, and a lot of people coming together, and you kind of think about what your role is on that project. And, it's a really beautiful thing when it can come together. The principles include common agenda, shared measurement, mutually reinforcing activities, continuous communication, and backbone support and infrastructure to support that. And in my world, one of the most successful ones has been Be More for Healthy Babies. I talked about this with some of the students today, which is a collective impact effort to reduce adverse birth outcomes and support young families in Baltimore. And when we started, we had one of the highest infant mortality rates for cities, and we've gone to one of the lowest, historic declines. There are over 100 organizations that work together with a backbone organization that's actually at the health department. The School of Public Health plays a really important role in putting together a lot of the communications materials for this, in addition to helping them raise money in different ways. The University of Maryland School of Social Work gets a special shout out. They went out and got additional grant funding and put together a really, really interesting component aimed at really helping the parents with employment and skills. And they saw in some of the most impoverished neighborhoods some of the best infant mortality rates. It was really just an incredible project. But everyone kind of feels pride in it. That's what makes it a collective impact project. Everyone's doing a part of it, and there's this overall goal. So if insufficient connection to communities was one of the challenges, and we talked about some of the solutions, I want to talk a little bit about inadequate public engagement. And I want to start with a case. A local health officer discovers that his town's main attraction, which is a natural water spring with baths, is contaminated. He intends to tell his brother, the mayor, right away so the baths can be shut down. He says it is a splendid thing for a man to be able to feel he has done a service to his native town and his fellow citizens. Unfortunately, the baths are a major economic engine of the town. And so his brother, the mayor, is adamantly opposed to the idea of closing the baths. The local newspaper, which initially had been eager to print a story about the fact that the baths were contaminated, now worries that mass unemployment could result and won't print the story. The health officer is shocked that people won't listen to him. And he says, I propose to raise a revolution against the lie that the majority has the monopoly of the truth. We have to believe in truth and not just all these people who are afraid of losing their job. And there's this huge meeting in the town, and the meeting essentially declares that the medical officer is an enemy of the people. You guys know this case? It's An Enemy of the People by Henrik Ibsen. I think it was written in 1882. Okay. Really, really interesting play. We find out in 1882 it's not so easy to follow the science to protect public health. Economic and political considerations intervene. This play introduces an archetype of a crusading public health official who is also haughty and intransigent. There is a scene where he just starts berating the public. He starts saying, like, look, I'm trying to keep you safe. And then he just says, basically, you're idiots to everybody. And they turn on him. And the play ends with the health officer ostracized but unrepentant. So now we're 140 years later, and we have the COVID pandemic. The COVID era, it's not so easy to follow the science to protect public health. Economic and political considerations intervene. Attacks on public health officials portray them as haughty and intransigent. And the politics of public health regulation remain potent, complicating efforts to control a global pandemic. And, let me just say, what do we mean by politics? There are a bunch of different definitions. The one that I would like to use here is who gets what, when, and how. Societies have to figure that out, ideally without violence, and that's politics. And there are a lot of external challenges to public health policies that are going to try to figure out who gets what, when, and how. It's political if a public health policy comes along and is going to try to do that. And there are different kinds of external challenges. There are economic interests. There's read my lips, we need tips, people getting really upset that they're losing their job. Judicial interventions. In this case, the Supreme Court ruling a drug compounding ban is illegal, but, the Supreme Court got involved in COVID too. Political polarizations, where people are, told to do things because of who's in power from the election. And it's a really tough challenge if you're thinking about this. Do we say, well, we're in public health, we know what's right, everyone should just listen to us? You're pretty close to Thomas Stockman's, intransigence, but on the other hand, you can't just bend to forces that are going to allow people to die. So it's a challenge, and this is where public engagement becomes really important. And so a question, the way I think about it, is it interference with public health, or is it kind of democracy trying to do politics? How do you think about that? Do economic interests matter? I would say they do. You can't, economic deprivation has huge health impacts. That's one reason. But more generally, we live in a society where there are different values and different things people do. All of us at some level probably trade off our health for economics, right? We might take a job that is a little bit harder on us because we need more money. That is a trade-off between health and economics. We are in the world of trade-offs in the real world. Are judges allowed to apply their judicial philosophy? They are. That doesn't mean we can't argue with them. But we live in a democracy where judges get to do that. Can people stand up for what they believe? Aren't they allowed to protest? They can. And I think peaceful protest particularly is really important. And that protest could be against public health because people are expressing their views. So it's kind of challenging to think about how, when we have this kind of challenge, how are we supposed to navigate through that? I'm going to tell you a case from my experience at the Food and Drug Administration. Turns out that the food that on a mouthful by mouthful basis is one of the most dangerous in the entire world is raw Gulf Coast oysters in the summer because of this bacteria called Vibrio vulnificus. And when I was at FDA, we hired the first deputy commissioner for foods, the FDA. And he came to meet with me and he said, "Josh, you're the principal deputy commissioner. What are your ideas on foods?" And I said, "Well, I know that these raw Gulf Coast oysters are really dangerous. And when I worked for Congressman Henry Waxman, California put in place a process not to cook them, not to require them to be cooked, but to require them to be pressure treated. And it eliminated these horrible deaths. People die these horrible deaths. It's like they lose all their skin, they die of these painful septic deaths. And the classic story is like someone on their honeymoon, it's a little bit of baseline liver dysfunction, they eat some of these oysters and they're dead in 2 days, having just suffered relentlessly, right? And it's all preventable. And he said, "Josh, that's illegal. Under our law, that's illegal. If you can deal with the hazard, that's illegal." And what a coincidence, because this very weekend is the Interstate Shellfish Sanitation Conference, which is the regulatory oversight of all the seafood. I don't know if you're all familiar with that. Not here in Oregon, but it exists. I think it still exists. I'm going to go there and just tell them, you can't do this anymore. You can't sell raw Gulf Coast oysters, And I was like, well, do we just want to announce it? Should we tell people? Should we engage with them? He's like, relax. You've hired someone, who understands this, and we're gonna do our best. So he goes out there. He says, this is what's going to happen, and did not go well. Okay. They were surprised. They felt like it was unfair. In fact, I don't have this on this slide, but all the newspaper reporters had a chance to either go to a food safety lab and talk about Vibrio vulnificus, or go to the French Quarter and interview people who are very unhappy with the FDA's action. And you can guess where all the reporters went. And it was like a wipeout. Someone is worried about the loss of a tradition that dates back 3 generations in their family, and they want to know who the, pointy-headed idiots who put this policy into place are. That was the kind of gist of a lot of the stories. And there was huge pushback. We wound up retracting the policy under pressure. And in fact, in 2016, Congress gave a role for the oyster industry in future regulatory decisions about what to do. And there have been exposés about how many people have died since. It was totally failed regulatory effort. It was the wrong way to go about it, and we had a terrible result. And I, tried to learn from that, because right around the same time, we got a letter asking the FDA to move on a different product called caffeinated alcoholic beverages. How many people have heard of Four Loko here? Yeah, everybody's dating themselves to a certain generation if you've heard of Four Loko. Four Loko was a drink that each can had about 4 beers worth of alcohol, 4 or 5 Diet Pepsis worth of caffeine, and a few Krispy Kreme's worth of sugar. And kids were going to parties and they were being given one for each hand and told that they had to drink them both before they could come in. And it created, when you add that much caffeine, it creates a state of like wide awake drunk. And there are tons of injuries, assaults, car accidents, alcohol poisoning. And it was just awful. And so people were raising this to us. But this time we didn't just jump out and ban it right away. What we did was we alerted the public of the concern. And we said we wanted to give the companies a chance to provide evidence that adding caffeine to alcoholic drinks was safe, because caffeine is a food additive under FDA law. And there were a lot of articles like this one, FDA questions the safety of caffeinated alcoholic drinks, but we didn't take immediate action. We used time to build understanding of this. And then we started getting pressure against us to take us off the market. So, okay, we weren't like jumping in and doing something and trying to explain it later. We were trying to educate and build support and, not knowing where we would wind up, but see what kind of support there was for regulatory action. Eventually, we announced regulatory action with Republican and Democratic state attorney general, the CDC, the Federal Trade Commission, and others. And we actually included in that a full explanation of what we were doing, how we had listened to people in this process, and lo and behold, they came off the market. We got headlines like this. There was even a better headline that was Four Loko to be converted to gasoline, ethanol. So I have that framed in my office. Recently, the generation that really was of Four Loko are becoming like podcasters and documentary filmmakers. So they're like, one person called me and said, "You mean to tell me there's never been a movie about Four Loko?" And I was like, I don't think there will ever be a movie about Four Loko, but but who knows, I did do a podcast with somebody who has like a podcast about alcohol. And he started out by saying, "I love Four Loko, it's like my favorite drink." And by the end he said, "I think you saved some lives there." It was a really good conversation. So how do you get into public health policy? Should it be done in a way that is as effective as possible and is least likely to cause that kind of backlash that we got with the oysters, more likely to have a better result where when we took that action against Four Loko, that it was able to stand up? So a few things I would say: really make the case first. Now, you notice I'm giving a lot of examples that aren't COVID, but that really wasn't done all that well, in my opinion, during COVID. That oftentimes it was like you woke up and you heard what the new policy was. It wasn't like, here's what we're thinking about, here's the case, we want public comment on it, we want to engage people. Now, at the very beginning, when it was like, totally chaotic, that's understandable. But over time, I think there could have been a lot more opportunities. A lot of people called me and asked me for ideas, and I often said, have a public comment period. But people were really anxious about doing that. And I think that didn't make it some of the back and forth easier. Be transparent about the data you're basing things on and why you want to do it. Provide opportunities for engagement and participation, even if people will disagree. And respond to criticism. Oftentimes at FDA, we would do this. We would respond to criticism on both sides. And when we were able to do that, people would see why we're taking the position we are. So like you could say, how many days should you be on, isolation after a positive test? Here's the argument for 5, here's the argument for 7, here's the argument for 10. Let's get some public comment on it. Let's see how people feel about it. And then you see where everybody else is. And it's not just the agency moving forward, boom, and then everybody hates it for different reasons. If we do these things, I think public health officials, when people get upset, can redirect people to the process. There's greater public understanding and support. There's greater procedural and substantive record for court proceedings. So there's a legal argument, and there's enhanced trust in the agency. Oops, I think I doubled the slide, perhaps. I want to end with this case. If you think, that's easy to say, Josh, on some issues, but what about other issues, really hard issues that are really ideological and difficult. I want to talk about how we tried to do this on abortion. Okay, and we had a really unfortunate case in Maryland where there was a abortion that was started in New Jersey and finished in Maryland, and it was like all kinds of horrible complications. And people jumped up in Maryland and said, like, what's going on here? Like, this is not safe. You know, what's going to happen? Do we need legislation or not? And it turned out that the health department had regulatory authority. We could come up with a policy. And again, we could just like make it up in one day and announce it, but we didn't do that. We said that we were going to have a process of public engagement. We met with experts in multiple disciplines. We reviewed the experience of other states setting regulations on abortion. We met with advocacy groups across the spectrum of views on abortion. We actually posted a draft of our regulations and the explanation for it and got comment. And then we proposed a rule which required a license to do surgical abortions in Maryland and a set of conditions for the license based on evidence and authority for inspections. And then we published that final rule. So the whole thing took about a year, right? And you might think, well, you try to do that, it's just people are just going to get angrier and angrier and angrier and angrier, but that is not what happened. We had a fabulous person leading that effort, the Deputy Secretary, Fran Phillips, nurse. And the result is when we came out with the final, adopting guidelines for abortion clinics, the head of Respect for Life, a division of the Maryland Catholic Conference, said, we think the rules will go a long way in protecting the safety of women. And the head of Planned Parenthood has called the state's licensing rules reasonable and helpful. Okay, and that took a lot of work. That is a skill. That is a muscle to be able to do in terms of public engagement. But as I think about kind of how public health has to work, it's not just, you know, to make connections with community, work with communities, but then when you're making policy, really listen, be fair, be transparent, try to explain things. It is not a guarantee, and with misinformation, everything, it can be very hard. But I think it's something that we need to do better. So my conclusion is that public health is facing enormous post-pandemic challenges. Restoring community and public connection, putting the public back in public health is a critical piece for regaining trust, but it is a shared challenge too. There are critical roles for public agencies, funders, community collaborators, and academic institutions. I think it is really a critical role of the work of public health going forward. I'm just going to end with a quote from Dr. Stockman of The Enemy of the People, which is, you should never wear your best trousers when you go out to fight for freedom and truth. I think that rings true. This is a really difficult line of work we've chosen, but it is incredibly rewarding. And I really appreciate the chance to be with you today, and I'm excited to answer your questions. Thank you very much.
We've got runners with minus. If you got questions, raise your hand.
Do you want this?
Sure.
For everybody else.
Whoever's next, you should go. Yeah.
Thanks so much for being here. Wow, that's loud. You talked about public engagement as a muscle and a skill that you have to build. It's really, really, really hard to sit in that fire with people as they go through, that's a terrible idea. It's not based on the evidence. Actually, it is. It's a great idea, right? We've been through it. There's lots of supports. How do you build the muscle?
Sure. So let me just tell you, I've had a lot of experience in different ways. One of the things that I've worked on over time is helping municipalities put together overdose response plans with a lot of public engagement. And you know, people have very, very different ideas on what's needed. And they can be quite mean online about what they think. You know, we did a public comment period in one state, and people wrote, we just shoot the drug dealers and hang their bodies from the welcome to the state sign, you know? And so in person, people are it's much harder for people to be that like that. I know that that's not entirely the case if you look at some online videos, but like I have some ideas on how to try to lower the temperature in that situation. And one of them is I don't like a microphone that everybody's lined up on. I think that is like triggering setup. And people are just like, my turn, is it my turn? When's it my turn? And then you go, okay, we're done now. And then everyone goes, I haven't gotten a chance to speak, really, really hard. Like the actual organization of public comment sessions is really important. So what I tend to do is ask people to sign up in advance, organize them into panels, and have them come up and sit down and be seated, have 2 tables. They're giving testimony to the public officials or whoever it is. Often it's like have a couple community members as part of a group to receive the ideas. And you have the panel, and maybe it's on a topic, but people can have different views of it. Like harm reduction. We're going to have a harm reduction panel. We're going to have 4 people. First person gets up and says, harm reduction saved my life. Let me tell you what happened. And the next person showed up, didn't like harm reduction that much, but they're a human being. They hear with that, and then they kind of moderate a little bit. And then you ask questions of people. It's just like people feel like they're shouting into the void. You don't want people to feel like they're shouting into the void. So you ask questions like, well, you heard how this person said that harm reduction saved their lives. How did that make you feel? You can ask questions like that. Put people on a little bit. And so they're engaging, and you actually can get to a little bit more understanding and knowledge about the problem, and people can feel more listened to. I'm not saying that it's like a magical solution, but these are the kinds of things you really have to think about if you're going to take it seriously and not have it actually get worse when you bring people together and people like screaming at each other. I saw like a lot of these school board meetings and how they were organized, and I thought like it's almost like a classic situation for how to just have people just irate beyond belief at the end. So I do think it is a muscle. It's a hard one, but I do think it's worth. Public health should do a better job in implementing it as more regularly. Yeah.
But
I think you just have to click your heels 3 times.
thanks so much. This was very thought-provocative, Dr. Sharfstein. I'm almost wondering if we're really thinking about the future, if we need to step back and think about what happens in middle school, what happens in high school, when we start to teach our future populations about how they look at data, how they look at evidence, so that when they eventually age into coming to these community organizations and being part of the conversations, they are perhaps differently literate about why evidence matters. And this may not be at all where you're going. I certainly, I'm with you on all the stuff about community engagement. You know that I work with Extension. But I almost think that we have to build that capacity that may not really be there right now, or is there in different pockets.
Yeah, well, I mean, it's interesting that public health, for example, isn't really a course for middle and high school students. It isn't something that's taught at all. And so that is a, one gap that's there. But it's challenging, and, education is extremely politicized now. So it's, how to get there is probably beyond me. I think, places that have public health school, education schools should be thinking about what can be done in that area. Joe?
Someone's giving me a microphone now. Is there one in the back then?
Yeah, after you.
Okay. I am wondering, so thinking about these, when we're confronted with public health crises like this, what are your thoughts on how we balance that juxtaposition of we've got a workforce of public health professionals who are chomping at the bit to push out rules and regulations about how to keep people healthy. We're trying to do that work, and a need to create public buy-in. But when we're faced with crises like we were with COVID, how do we kind of sort of balance that juxtaposition there?
Sure. Sometimes you can do something like you make a decision, you take public comment afterwards, and you say, hey, we're going to be closing the bars and restaurants. Here's our logic today. We think this is an emergency, but we are going to set up a 2-week public comment period, and we're going to have a public meeting about it because we want to understand the consequences of it. We want to understand if we can mitigate it, and we want to understand whether people think this is justified, because we can change our minds. You didn't really hear that much. It was just like, we're going to close bars and restaurants, which I personally think at different times of the pandemic was absolutely the right thing to do. So I think even in an emergency, even if you can't like take a lot of time to make a decision, there are ways to signal that you care about what people think and that you've heard people, And when we did go into states and we helped them with opioid plans, people will write all kinds of things. People will say all kinds of things. And when the plan comes out, I recommend, and most of the places we work with have done this, a companion document that lists the comments and explains which ones were adopted and which ones weren't. So you see that there was some listening, and people can say, okay, I said that they should, hang the drug dealers and, from the welcome sign, and they said that, was a cruel and horrible thing, and whatever they said, but like at least you see that people read it and listened to it.
As a leader in a public health agency, how do you like create that buy-in for the people who have to go out and like sort of man the front lines in that work? Like, how do you create that buy-in for other public health professionals who aren't decision makers but are the enforcers of those decisions?
Yeah, it's hard, and especially if people aren't used to doing it, to get people to do that, and you have to spend some time and listen to them and also make sure that they're protected. I did this public outreach once on a gun legislation after the Newtown shooting. And we had a meeting, public meeting in Baltimore, which is a city that generally is pretty supportive of gun measures. And so everybody walked in thinking like it was going to be fine. And then, every opponent showed up. Like 99% of the room were people who were furious, thought this was taking their guns away. And it was like super stressful. And then we went to another meeting and it was similar to that, different part of the state. And we sort of were like, thank you very much for your comment. It was really demoralizing and frustrating, because felt like we couldn't really have a conversation. It was just one thing after another. Went to the third one and we all kind of went in like this. And this one was in Montgomery County, and there was a county executive there who was a very distinguished older gentleman. I had no idea what he did. He was always very sweet. He had a very grandfatherly demeanor to me. So the first person got up and said, "How dare you, take my guns away?" And he's, I fought for my country, and I have a right, and you can't take them away. And we were like, "Thank you very much." And he said, "Hold on one second." And it was like, everyone was like, "What?" And he said, "I fought in the military. I'm a professor of constitutional law." I was like, "You're a professor of constitutional?" I didn't know that, And then he said, every right has its limits. You can't yell fire in a crowded theater. You can't ring the church bells in the middle of the night, And we fought for a government of laws. And if the law is the law of the land and there's certain limits, we're going to have to abide by them, And suddenly, like, the entire complexion of the room changed. It was a conversation, and the person said, "I thank you for your service," It became like a much more of a dialogue. It was really interesting compared to how the other meetings went. So I think, setting the conditions correctly, because I experienced the first couple is like really demoralizing, and it was frustrating for everyone. It's frustrating for the people who were there. And then by the last one, it was much more of a conversation about, what the purpose of this was and what the limits were. So I think your point is very well taken. It just brought me right back to that place. Yeah, all the way in the back there.
Hi, thanks. Given that we've lost 40,000 public health jobs in the last 15 years, which I didn't realize it was quite that bad, and that we should have more job paths for people who start as traditional health workers, community health workers, that sort of thing, what are your thoughts on the number of graduate students we collectively are training?
Yeah, well, there are a couple. I will get to that. Just for context, I think it's really important that there be much more support for local and state public health. And I was involved in the Commonwealth Fund Commission for a National Public Health System, which recommended that Congress provide sustained support in exchange for local and state health departments meeting certain foundational capabilities, which include some of the community engagement things that we talked about, that there should be essentially a deal. You'll get money, but you have to deliver high quality public health. That is kind of the deal that's been really helpful in some states, including Indiana, a red state, to get a lot more funding for public health. So I think that out there is the idea that if public health could, strength becomes stronger, that people will invest in a very community-based form of public health. I think that can cross political lines in gaining strength. So it has all these implications for education. A lot of people in the field don't have degrees. That's a big challenge. And one major question is, what kind of education can be given to them, to support people who are in the field, and what kind of credentials are appropriate in the field? Can we have more standard job classifications? I think that's really important, so that if you do a job in one place, you can go to another place and you know what the job is, and it's not like, well, you do 8/9 of it, but not the last 9th, and everybody's confused, which is a lot of what public health is. There's a gap between what people in the field say they need and what public health schools train. And I think that effective workforce policy has to bring it all together. It should be that the degrees are lined up with, more clearly with jobs that people can do, that the job classifications are more clear, that they're more portable from place to place. I think that would really help, create much more of a backbone structure to this. If you think about medicine as a counterpoint, there are really clear standards for what it takes to be a doctor. There's clear standards for different credentials like advanced life support or pediatric advanced life support. And then people can take that and move around, and it's really clear what those, people say, like, there needs to be more addiction training, and people, okay, we know where to write in the addiction training. But public health is just much looser. So I think there's a lot of work that needs to be done in workforce. I don't have an answer for the number exactly. We have a lot of people getting public health training these days. A lot of people who do that don't go into the public health field. So I think it's more the structure that needs to be put in place, at least as a foundational part of that.
So I have a comment and a thought, follow up on a previous question about earlier life education, and perhaps and it connects his ideas too, is that high schools have debate teams and debate classes, but it's debate to win. But maybe we could also develop programs where they debate to collaborate. So what he's talking about is you have this discussion between different groups of people. So instead of just debate to win, could they debate to collaborate?
Right. Like be on the high school mediation team.
Yeah. Learn how to negotiate. High schoolers have a hard time with that, but, it's just a thought.
That's right.
So in these kind of crises situations that you've highlighted, I think it's just expected that, we're going to get some of this decision-making wrong at times. And how do you think we should approach, explaining decisions that maybe didn't go the right way, and how you explain that to the public so that you maintain that trust, for public health officials?
So it's extremely hard, great question, extremely hard to be successful when there are a lot of people of bad faith out there, right? Because you can say, this is what we know now, here's what we're doing, we think, it doesn't make sense for people to use all the masks that are out there, or whatever they say, but that could change. We're learning every day, and then people report it as like, no masks, says health, and then people are like, you've changed your mind, and it's like, it's very hard. And I don't mean some people are just, confused. I just mean people are actually just trying to attack. And I think that was unfortunately part of the picture and became more of the picture as the pandemic went on. So the degree of difficulty of this is very high. But my feeling is that in public health, we traditionally think about communications as getting the words right. What do you say? And I told this to some of the students in one of my classes. I had this ex-FBI person come and talk about misinformation in the media environment. And he said, basically patted me on the head in front of all the students and said, so cute. You guys think if you get the words right, that people are going to believe it. He said, you work and you focus group and you do all this stuff in your message. And in the meantime, people are getting 10,000 times some other message, calling you corrupt, calling, down, up, or whatever it is. It's coming in through their WhatsApp, closed groups. It's coming in on Facebook. It's coming in on Instagram, Twitter, X, whatever, and they're just getting deluged with bad information. And so that is a very, very serious challenge too. So this challenge that you're talking about, it was a lot easier when it was a much more narrow media environment, when reporters were generally, more responsible, because you could say, I might get this wrong and we're going to be back here and talk about it differently. People would actually believe you and then they would give you a chance, Now it's very, very hard. And I think you have to have different strategies. One of the really key strategies is to have an intermediate layer of communicators who you're going to work with in communities. Like, you really have to win the in real life communication game. It's like those 300 people who are going to be working with the health commissioner to get the word out across the city. You're going to have to talk to them a lot. You have to give, answer their questions, explain why we're doing something differently so they can explain it to people one-on-one. And you have local people who are trusted, who are saying things, Like, I gave a lot of advice, which some people took, like, hey, if you're going to announce this, why don't you have an ER nurse next to you? Why don't you have one of the businesses in town next to you? Why don't you have, one of the business leaders? Like, bring people together so it's just not you doing this, I remember during the Ebola crisis, Tom Frieden was testifying, the CDC director was testifying before Congress and saying, look, I don't think Ebola is going to sweep the United States. And one of the members of Congress said, this is just like a movie where people come in and they say, this is the first scene. I don't think it's going to happen. That makes me think it's going to happen. It was just like, oh my God. So we were in Maryland and the governor said, well, I want to have a press conference with you to tell people that we're prepared for Ebola. And I said, how about we bring, Johns Hopkins, MedStar at the University of Maryland. Everyone's going to come and say we're all on the same team. And let's bring someone from the West African expatriate community here who can talk about how they're working in their community. Let's just try to demystify it. We're all standing. And it was much more successful than other places where there were a lot of different challenges. So, I think we have to just think about the communications challenge differently now. But having said that, it is a really, really difficult time. I went to elementary school with Rochelle Walensky, the CDC director. I was the shortest kid in 6th grade. She was the tallest kid. So I always told her I've been looking up to her for a long time. But I said to her, she had so much harder job than her predecessors because she was in an environment that was just ready to rip her apart for anything that she said. And it just creates just this enormous challenge. And it's one that I think we have to be doing things differently. I think every health department needs a misinformation person, who's really monitoring what's out there and thinking about how people are getting confused and trying to jump in because the misinformation could be coming in through just one group, could be coming in a different language just for one group. And to really spot that and be able to respond to it, that's not like a put out a press release kind of communications person. It's a really fundamentally different kind of skill that's needed. Yeah.
Thank you so much for this amazing presentation. So actually, I'm a first-year PhD in health policy. So I would like to ask, for us, we're starting our career in public health, so what kind of skills you suggest so we can master or have a hand-on experience that will go a long way, and keeping in view that we are as an international student, so we are just starting a career in public health.
Well, that's a good question. There are many different careers in public health, and it is such a great field because you wake up every morning and you're trying to make your community healthier. It's just such the best feeling, I have to tell you, and even when it's hard, you're trying your best for things. I think that it's really important to learn, when you're in school, like what really is most likely to work, what are the best approaches, and always have in mind what the right thing to do is. I think part of the challenge out in the world is you can't always do the right thing all the time right away. You have to fight your way to get there. You have to be strategic. And putting yourself in different kinds of positions to get a sense of what kind of career you want while keeping those principles in mind is really important. I get asked a lot this question: how can I have the biggest impact in my career in public health? I get asked that all the time. In fact, in my head, there's like a montage, like a movie montage, where I'm like looking at a student or even a faculty member who comes and goes, I need to know what's the secret to having the biggest impact, and making the most difference. And the truth is, there are a lot of ways to have an impact in public health. If somebody does an incredible research project and changes the way people see something, it can have a huge impact. If somebody partners with a public agency and helps them navigate through different problems and put in place a policy that really works, that can have a huge impact. You can work for the public agency. You can be a critic of the public agency and get them to change. There are so many different things. What students, I think, need to do is figure out where they're inspired to do work, where they're comfortable to do work, where they're inspired to do work. You should try different roles, see what makes sense. I had a friend, at one point, we were both very unhappy with the work hours of young physicians. Like, we wasn't the 60-hour shifts that my parents did, but it was like 36-hour shifts pretty routinely, and it was too much, and we felt like we weren't doing a good job for patients. And what he did was he played Tetris. Do you guys know what Tetris is? On the street corner, and invited the media to watch his scores go down as he was staying up for hour after hour after hour. And so they were like reporting, like, his kid's playing Tetris. He's like, I'm still in the shift if I'm in the hospital, Now, I find that very creative, but I could never do that. It's just I couldn't do it. But I could write a piece saying it's time for medicine to change, even one that was maybe not all my professor's favorite piece. I was comfortable doing that. But other people might actually do a research study on issues. And there's just a lot of different ways. And so I think everybody in public health should share the true north of a healthier and more equitable society, but we're all working in different ways to get there, and that's okay. You're finding where your passion lies. So maybe we'll call it there. We're about 15 minutes past the time. There's obviously, we've been competing against the aroma of food here, so you can all go. It has really been a pleasure to come. I really want to thank Dean Bray, and special thanks to Marie.